So we were discussing the function of trigeminal nerve or cranial nerve 5. And the function of trigeminal nerve or cranial nerve 5 is the sensation from the face, pain and temperature sensation, and afferent limb of corneal reflex is the function of trigeminal nerve. Then there is cranial nerve 6, abducent nerve. The only function of abducent nerve is it supplies the lateral rectus, which is an extraocular muscle of the eye. As its name indicate, the function of abducent nerve is abduction of the eye. It supplies the lateral rectus muscles, which causes abduction of eye or outward movement of the eye. Cranial nerve 7 or facial nerve. Facial nerve supplies the muscles of facial expression. So the motor supply to the face is through facial nerve. The sensory supply to the face is through trigeminal nerve. The afferent limb of the corneal reflex is formed by the trigeminal nerve, and the efferent limb of the corneal reflex is formed by the facial nerve. So remember these two nerves together. Sensation from the face, trigeminal nerve. Motor supply to the face, facial nerve. Afferent limb or sensory limb of corneal reflex is trigeminal nerve, and motor limb or efferent limb of corneal reflex is facial nerve.
Sir, can you please differentiate between the afferent corneal reflex and efferent corneal reflex?
What is corneal reflex? Corneal reflex is basically if you touch the cornea, it will result in the blinking of the eye. So when we touch the cornea with a cotton bud, this message will be taken to the brain by the trigeminal nerve. So this part is afferent limb, the incoming towards the brain. The limb that is bringing the message to the brain is afferent limb, that someone has touched the cornea. Now what the brain need to do? Basically, it's a defensive mechanism. If something touches the cornea, the message that will be brought to the brain is basically afferent limb. Now the brain will send motor supply or motor message through facial nerve, which will causes the contraction of the muscles of the eyelids and which will result in the blinking of the eye. This is efferent limb. So you can say that sensory limb is afferent and motor limb is efferent. Is it clear?
Yes, sir.
Now the next nerve is cranial nerve 8, vestibulocochlear nerve. Vestibulocochlear nerve has two functions or two parts. One is vestibular part and one is cochlear part. The vestibular part is associated with balance, and the cochlear part is associated with hearing. So damage to the vestibulocochlear nerve will result in deafness or loss of balance. The function of cranial nerve 8 is balance and hearing. So damage to the cranial nerve 8 or vestibulocochlear nerve will result in loss of balance or deafness. Now glossopharyngeal nerve. Glossopharyngeal nerves supplies the muscles of the pharynx. It is a mixed nerve. It gives motor supply as well as sensory supply. The motor supply is to the muscles of the pharynx, and the sensory supply is sensation from the or sensory supply from the pharynx as well. So if there is damage to the glossopharyngeal nerve, there will be paralysis of the muscles of the pharynx, which will result in impaired swallowing or dysphagia and loss of gag reflex. Vagus nerve, on the other hand, supplies the muscles of the vocal cord. So damage to the vagus nerve will result in vocal cord paralysis and a condition which is called bovine cough or a weak cough. So damage to the glossopharyngeal nerve, loss of gag reflex plus impaired swallowing plus pharyngeal sensory loss. While damage to the vagus nerve will also result in the absent gag reflex, because similarly as like trigeminal and facial nerve, the afferent limb of the corneal reflex was formed by the trigeminal nerve and efferent was formed by the facial nerve. Similarly, the afferent limb of the gag reflex is formed by the vagus nerve and the efferent limb is formed by the glossopharyngeal nerve. So damage to any of these two nerves will result in the absence of gag reflex. Plus, how will you differentiate that it is a lesion of glossopharyngeal nerve or a vagus nerve? You will differentiate it by if there is dysphagia or impaired swallowing, then it is glossopharyngeal nerve. And if there is aphonia or weak cough or bovine cough or non-explosive cough, then it is vagus nerve or cranial nerve 10 damage. Now, the 11th cranial nerve is spinal accessory nerve. Spinal accessory nerve supplies the sternocleidomastoid muscles and trapezius muscles. So, a damaged or lesion of the cranial nerve 11 will result in the shoulder weakness and head movement will be affected. The last nerve is hypoglossal nerve. Glossal, it supplies the tongue, the muscles of the tongue. So, a damage to the hypoglossal nerve will result in weakness of the tongue. Is it clear to everyone up till this point? Any question anyone want to ask? No questions?
So this
Okay.
hypoglossal nerve is ipsilateral region deviation toward the normal side, the
Remember
same
that,
side.
remember that for all the cranial nerves, for all the cranial nerves, the lesion and there will be an ipsilateral findings. Like if there is damage to the cranial nerve, third right-sided cranial nerve, then the lesion will be on the right side. Everything will be ipsilateral in case of cranial nerves. Now, ipsilateral horror syndrome. Ipsilateral oculomotor nerve palsy. So, what are the signs of oculomotor nerve palsy? What are the three signs of oculomotor nerve palsy? Can anyone tell me?
Sir, it's ptosis,
Yes,
mydriasis, and all
mydriasis and
all extraocular muscle paralysis
what?
except lateral rectus superior oblique.
Yes, down and out eye. The eye will be deviated downward and outward in case of oculomotor nerve palsy. So patient present to you with oculomotor nerve palsy plus contralateral hemiparesis. So the lesion is on the left side of the central nervous system. The lesion is on the left side, so there is left oculomotor nerve palsy, and contralateral hemiparesis means right arm plus right leg is there is weakness of right arm and right leg. So if someone present to you with hemiparesis plus cranial nerve sign, then the lesion is most likely in the brainstem. Like in this case, the lesion is at the level of the midbrain because the patient is presented to you with oculomotor nerve palsy and arm and leg weakness. This syndrome is called Weber syndrome, which is due to midbrain infarct and due to blockage of posterior cerebral artery. So if there's blockage in the posterior cerebral artery, the patient will present to you with signs and symptoms of oculomotor nerve palsy plus contralateral hemiparesis. As you can see that the cranial nerve palsy is on the same side, at the side of the same side as the lesion, and the hemiparesis is on the opposite side. So this is called crossed hemiplegia. Remember that the brainstem lesion will always produce crossed hemiplegia. What is crossed hemiplegia? The cranial nerve sign will be on one side while the hemiparesis will be on the opposite side. Let's do another example. So loss of pain and temperature sensation in face plus contralateral loss of pain and temperature sensation in limbs. So which nerve brings pain and temperature sensation from face? Can anyone tell me?
Trigeminal, trigeminal.
Yes, trigeminal nerve bring temperature, pain and temperature sensation from the face. And where is the nucleus of trigeminal nerve located?
Pons.
Yes, it is located in the pons. So trigeminal nerve enters in the brain through pons, and then the fibers that are bringing pain and temperature sensation, they travel downward through medulla, and they form synapses at the level of C2, cervical segment. So basically you can say that the fibers that are bringing pain and temperature sensation from the face, they enter in the pons and then they travel downward in medulla. So if there is loss of pain and temperature sensation in face, then we can say that the lesion is at the level of medulla, because the fibers that are bringing these sensation, they are passing through medulla, plus contralateral loss of pain and temperature sensation in limbs. This syndrome is called Wallenberg syndrome, and it is due to posterior inferior cerebellar artery blockage.
Sir, this I didn't get it that this is in the bones, but you said in medulla. How? Can you explain this again?
The fibers that are bringing pain and temperature sensation from the face, they enter. Remember that trigeminal nerve has, why it is called trigeminal nerve? It has three branches and it has three nucleus. One is the main nucleus, and one is the mesencephalic nucleus, and one is the spinal nucleus of trigeminal nerve. The main nucleus lies at the level of the pons. The mesencephalic nucleus lies at the level of midbrain, and the spinal nucleus of trigeminal nerve, which is associated with the pain and temperature sensation, it lies in the medulla. That's why it's lateral medullary syndrome. Though the main nucleus of the trigeminal nerves lie at the level of pons, but the fibers that are bringing pain and temperature sensation, they ends in the spinal nucleus of trigeminal nerve, which lies at the level of medulla. Is it clear?
Yes, sir.
Let me see if I can show you a diagram, then it will be more clear. So what is Weber syndrome? What is Weber syndrome? Anyone?
Sir, Weber syndrome is posterior cerebral artery block. That is
Yes,
ipsilateral oculomotor nerve palsy plus
yes,
contralateral hemiparesis.
yes. And what is Wallenberg syndrome?
It's ipsilateral Horner syndrome plus
Yes.
loss of pain and temperature in face and contralateral loss of pain and temperature in limbs.
What is Horner syndrome?
Sir,
Remember that.
it's
Yes, yes.
okay, sir. Can you please explain?
Horner syndrome is basically if there is a disturbance in the fibers of the sympathetic chain or sympathetic supply. Normally, the sympathetic chain lies in the paravertebral region, and normally hypothalamus sends the preganglionic sympathetic fibers. So if there is interruption to these fibers, it will result in the Horner syndrome. Now, like oculomotor nerve, in oculomotor nerve lesion, there were three symptoms or three signs: down and out eye, ptosis, and mydriasis. Similarly, in Horner syndrome, there are three findings. Remember that the sympathetic fibers supplies the pupil, or it supplies the pupil plus sweat glands in the skin, and it also supplies the superior part of orbicularis oculi, a muscle that is present in the eyelid. So what will happen if sympathetic supply is interrupted? Three things will happen. First of all, you all know that sympathetic system cause a dilatation of the pupil or mydriasis. So if there is no sympathetic supply to the pupil, what will happen? Normal function of the sympathetic supply is mydriasis. Sympathetic supply is interrupted, what will happen?
Meiosis.
Meiosis. It also supplies the sweat glands in the skin. So if it is damaged, what will happen? There will be no production of sweat, which is called anhydrobiosis. And it also supplies a muscle in the superior eyelid. So if sympathetic supply is damaged, then ptosis will also occur. So ptosis, anhydrosis, and meiosis. This is Horner syndrome. So ipsilateral Horner syndrome plus loss of pain and temperature sensation. Ipsilateral loss of pain and temperature sensation, and contralateral loss of pain and temperature sensation in the limbs. This is Wallenberg syndrome or lateral medullary syndrome. Is it clear, everyone, up to this point? Is there any question anyone want to ask? Dr. Shafaraz, do you want to ask anything?
Uh, no, I think it's pretty much clear so far.
Okay, thank you. Now, here again a general concept. Another way of telling that if it's a medial midbrain syndrome or a lateral midbrain syndrome or a medial medullary syndrome or a lateral medullary syndrome, you can tell it by remembering these important points, that which structures are present on the medial side of the brainstem or in the midline of the brainstem, and which structures are present on lateral surfaces or side of the brainstem. So four important structures are present in the midline of brainstem, or you can say they are present medially. The first most important structure is corticospinal tract. Corticospinal tract, as its name indicates, it starts from the cortex and it ends in the spinal cord. So it is called corticospinal tract. It is also called motor pathway because it controls the movement of the muscles. All the voluntary muscles of the body are controlled by corticospinal tract. And it is present in the midline of brainstem or medially in the brainstem. Motor nucleus and nerves that are present in the midline are cranial nuclei of 3, 4, 6, and 12. So cranial nerve nuclei 3, 4, 6, and 12 are present in the midline. Medial longitudinal fasciculus is also present in the midline, and medial lemniscus is also present in the midline. There are three important pathways that you need to remember to have a clear concept about neurology. One is a motor pathway, that is corticospinal tract, that starts from the cortex and ends in the spinal cord. It controls the movement of the body or voluntary muscles. Then the other two pathways that you need to remember are dorsal column tract, and spinothalamic tract. What is the function of dorsal column tract? The function of dorsal column tract is it carries the sensation such as fine touch, crude touch, proprioception, and vibration sensation from all the parts of the body to the brain. While spinothalamic tract takes the pain and temperature sensation from different parts of the body to the brain. Just give me a minute, let me show you a diagram. Now, as you can see in this diagram, a basic pathway of spinothalamic tract is shown. Spinothalamic tract, what is the function of spinothalamic tract? Spinothalamic tract takes pain and temperature sensation to the brain. It starts from the receptors, pain and temperature receptors. The first order neuron is in dorsal root ganglion. The first relay or the first stage in the dorsal root ganglion, then it enters in the spinal cord. So as you can see that the second synapses is formed in the spinal cord in the dorsal horn of the spinal cord. Remember that the dorsal horn of the spinal cord is related to sensation of the body or sensory function of the body is in the dorsal horn of the spinal cord, while the motor neurons are located in the ventral horn of the spinal cord. I'll repeat it again. Sensory neurons are located in the dorsal horn of the spinal cord, and motor neurons are located in the ventral horn of the spinal cord. So spinothalamic tract started in the receptors, pain and temperature receptors. They form the first synapse in the dorsal root ganglion, the second synapse in the dorsal horn of the spinal cord. Then you can see that they have crossed to the opposite side in the spinal cord. They went one or two segments upward, and then they crossed to the opposite side in the spinal cord. And then they went upside and reached the post-central gyrus, which is present in the parietal lobe of the cerebral cortex. Now let me show you another pathway. Now this pathway is dorsal column pathway, also known as dorsal column medial lemniscus system. So the first order neuron or the dorsal column pathway, they bring fine touch, crude touch, proprioception and vibration sensation from the body, like
Sir, first
spinothalamic
one
tract.
is after the first one which you showed was the first pic which you shown was also of the dorsal column pathway.
No, that was spinothalamic tract. The function of spinothalamic tract was to bring pain and temperature sensation.
Okay, that was spinothalamic. Now this is medial lemniscus, right?
This is dorsal column medial lemniscus system. Now I will tell you that they are the name of the same track. When you will call it a dorsal column and when you will say it's medial lemniscus system. For spinothalamic tract, two things are important to remember. One, that they bring pain and temperature sensation, and the other one is that they cross to the opposite side in the spinal cord. Now let's see how dorsal column pathway is different from the spinothalamic tract. The one difference between these two is that dorsal column pathway brings the proprioception, fine touch, vibration, pressure, and 2-point discrimination. All these sensations are brought by the dorsal column tract to the brain. Now, the first synapse is formed in the dorsal root ganglion, like spinothalamic tract. Then they enter in the spinal cord, and then they go upward. In the spinal cord, so spinothalamic tract cross to the opposite side within the spinal cord, while the dorsal column tract is not crossing to the opposite side. It's going upward, upward, and upward. You can see that in the medulla, this is medulla. In the medulla, they have crossed to the opposite side, and after crossing, these fibers are known as medial lemniscus. That's why it is called dorsal column or medial lemniscal system. What are the two important points to remember related to dorsal column pathway or medial lemniscal system? One is that it brings the proprioception and vibration sensation and fine touch, and the other is that it crosses to the opposite sides at the level of the medulla and after crossing it is known as medial lemniscal system. Now why it is
And
important
sir,
to
where
remember?
was
What?
so from where the spinal thalamic was crossing? It was
Spinothalamic,
crossing.
I'll show you.
Yes, once again.
You can see that
Yes, below
spinothalamic
the
tract
temporal
crossed to the opposite side in the spinal cord.
in the spinal cord. Okay, sir.
It entered here in the spinal cord, you can see, and it goes up one or two segment and then it crossed to the opposite side. Not at the level of medulla, it crosses in the spinal cord. So a lesion in the spinal cord, let's suppose